An elegant cut as the piezo is. There's a latch type burr that when we use it vibrates so much that the patients don't like it, especially under local. And it's slow so it won't burn the bone, but it's just not that elegant. There's the propel that you'll see on the convention floor with the 3, 7, and 9 millimeter little depths of holes. They sell them for about $150. In volume, you can get it for $100. It's disposable. They're now coming up with a disposable tip. And what they're doing is just puncturing. They just put a little puncture into there. I took a little TAD, and in our patients and in the skull, just to demonstrate, I just did the same thing, and it pretty much mimics it exactly. If you want to use the propel, it's got a little light that goes on when you get to the depth. If you feel like you could do it with your little TAD, you could do the same thing. The advantage of the propel or those TADs is it's minimally invasive. It goes right in. You could even do it with a burr, except not as fast as what I showed there, because you only cross the bone. I'm currently using the microscope because it allows me an accuracy that we haven't previously had before. We're working with a neurorobotic tool that we'll talk about in a little bit. But essentially, there you see the process. When you look at the literature, surgically facilitated orthodontic treatment, systemic review, it does a very good job of reviewing databases over a long period of time, and it's quite compelling towards the use of that. And so accelerated orthodontics is a modality that we didn't used to use that is a great help today. I like the little Pisa from Italy. There's my favorite tool. There it is with the water cooling so that the handpiece doesn't burn out. And here you'll see it demonstrated on a patient and how simple and quick. It's literally I think start to finish, including everything. We used to do it in the OR room, now we do it right up the chair side with a local injection and infiltration, blunt instrument to identify the root. I like using the Bovik for the control of the hemostasis. Very simple little incision right under there, and the local anesthesia takes minutes to do. And then taking a blunt dissection and going all the way up into the root, right, all the way up to the apex of the root, stripping away the bone, rather than doing what Wilcox does and do those full thickness flaps. And you have the expense of the periodontist and the healing that's much more morbid. And then you can see the piezo, and it's very quick, very effective, and go in and really do it. Go in and really do it on those teeth that you want to move. Based on the literature, if you go in and make a cut all the way up, that tooth will move a lot quicker than it would have if you hadn't, because of that regional acceleratory effect. On the cuspid, that is really rotated and angulated so severely. We'll do it on the bicuspid, we'll do it on either side all the way up the root. There you can see the access, and then you can see the piezo start going all the way up the root. And then a very quick single suture. If it's a small enough puncture, you don't even need to do the suture anymore. And next week they come in all done under local with very little morbidity at all. Here is another modality you'll see on the floor. They call it Accelident. We've used it on a number of patients. When you look at the studies and the literature, according to them, it's compelling, but it's slow. You know, patients who have a hard enough time getting them to brush their teeth, and you ask them to put this thing in there for 20 minutes every day for 9 months, and the compliance is not always great, and the evidence is not really fully compelling yet as to how effective this is. But they do come in a nice, convenient little tray. You can sterilize them quite easily, and it certainly is one of the modalities that will help accelerate them to how much we don't know. So on severe skeletal disparities, then we tend to not only do the piezo, but the orthognathic. And we do a large amount of orthognathic cases, and we feel like it will be, in the end, much more stable. It reduces the overall treatment time hugely. Sometimes a little from 3 to 9 months. 3 to 9 months start to finish, including the orthognathic surgery, very different to our old regimens where it was a year of ortho before and a year after. We'll go to surgery relatively quickly to take advantage of that regional acceleratory phenomenon, and we'll reduce skeletal disparities rather than try to camouflage it. Here you see a young man with an enormous overjet transferring into our practice, fully reduced into a nice class 1 relationship over a relatively short period of time, with a short course of orthodontic treatment. Here you can see him being prepped for his surgery with the appliances on, and you can see trying to accentuate more the class 2 in order to develop the mandible. And on him, because of the severity of the mandibular retrognathia and the mandibular asymmetry and the extent of the deformity and the root resorption prior to coming in, we wanted to do it quickly. We can't spend 2-3 years on treatment on him. And so we went and distracted it with those curvy linear distractors that Steve Schendel has patented, that allows you to almost steer while you're moving it. So instead of those old linear ones that would drive that mandible forward into a malocclusion, you can sort of steer where you want to go and direct it. And the orthodontist can do that right chairside by screwing that little screw and landing that occlusion nicely into a normal occlusion. So here you can see the nice facial changes that occur, and you can see the before and after with the distraction of the posteriors and the oblique view. Not only very severe cases, but sometimes also unsubtle cases. Here we have a patient with that came in and again trying to manage people's expectations rather than just treat with modalities that we used to. And we felt like by paying attention to some of the things that we talked about, we can learn people a little bit better, understand them, communicate with them, and reduce the amount of disappointment. She came in and didn't like the gummy smile. She didn't like the little extra fat underneath her chin. She didn't like the fact that her jaw was back a little bit. And she traveled a long distance to find an expert dentist, turns out, at Invisalign. And at first glance, it looks like a really simple case, and I think the dentist got sort of seduced into it. And he was one of those holistic dentists that believed in the 4-7 position that Gelb talked about, and he wanted to bring the mandible forward, and he said he could do it with Invisalign, and he charged her $10,000, and 2 years later, the teeth were a little straighter, but she still had all of this, and the gummy smile, and the can to the occlusal plane. And so he called his friend, the orthodontist, and said, I got into it over my head, and now she's a little more class 2, and could you take over? So $10,000 in, and 2 years later, she goes to the orthodontist, and the orthodontist takes a shot at it, and there he is using the mechanotherapy that Rick was critical of years ago. And another 2 years go by, he charges her another fee, and still nothing. Still nothing. He's having a hell of a time reducing that class 2. And she comes in and flies into our office and wants his second opinion because she's losing faith. And we take a look at her, and we look at her cephalometrics, and we look at her chief complaint, and we sit down with her, and certainly the things you could do by segmentalizing the arches and some of the things, Carl, that you showed us the Japanese do, and you probably could reduce that. But it wasn't her chief complaint. She didn't like all of that. And in centric relation, in that physiologic centric, it was worse. And it was harder than what the dentist thought it would be. And when he looked at her facial, she's not looking so happy anymore. She's 4 years into treatment, she's got fixed appliances, she's burned out, and she wants to be done. And so we went ahead and reduced her surgically, very quickly, with 6 weeks. Right after she came in, a little bit of pre-surgical prep. No fixation, splint for 2 or 3 or 4 days, orthodontics immediately after surgery, and you can see the nice changes that can occur. And a happy patient in a very short period of time, significantly reducing the amount of time and addressing the chief complaint a little bit more appropriately. There you can see the gingival display before and after, and here you can see what issues were she didn't like. That gums were a slant. For her, that was important. The dentist was thinking, well, let's just do a little bit of gum surgery. But he couldn't go beyond that CEJ very effectively. And you see the nice changes that occur before and after treatment. In a very, very short period of time, with the occlusal results that can be achieved by putting her through the ringer using an individualized prescription and paying attention to her chief complaint. Recently, there was a guy that flew in from Florida, and he had gone to the surgeon up at Stanford for sleep apnea. And the guy was so angry. He said, I wanted him hit. He's a big guy. I wanted to hit the surgeon. And I said, why? He says, because he fixed my sleep apnea, but look at me. He says, I'm crooked. I don't have a bite anymore. My teeth are all crooked, and it's just, so managing people's expectations. They've done it with arch bars. And I have a bias, and that's that orthodontists should be the ones, we see them before, we see them during, we see them after, and we should be controlling some of these patients. I really believe that we're in the best position to do that. And so the problem was now he's had the orthognathic surgery, and the surgeon's saying, what's the matter? He says, how's your breathing at night? And he said, it's good. And he says, what else do you want? He says, well, my teeth are all crooked. He says, well, go to the orthodontist. I'm not an orthodontist, I'm a surgeon. So he comes down to me, and I break the bad news to him, we have to do jaw surgery again. So he's just been through jaw surgery, I've got to do jaw surgery again. So he has another case, very similar. She came in, similar type thing. You see, sleep apnea is fixed, but her nose is crooked. She can't breathe through her nose now. She's got a class 2 malocclusion, and she's just had orthognathic surgery. So, you know, we go ahead and put her back in the brackets and reduce the malocclusion. We go ahead and put her through the orthognathic again. And there she is, before and after. A 2-stage surgery, one to address the jaws and bites, and then we offer her the option of going ahead and doing a little rhinoplasty and a little bit of the tissue over there. There you can see the nice changes that can occur, but still a little bit of crookedness of the nose. And here you see the plastics VTO, where you can change the nose and do the final little divisions of surgery. For those of you that are interested, we have a lot of the soft tissue changes documented in a chapter that we wrote in a book that I can get to you with the orthognathic surgery. We've also written up a lot of the protocols in the literature, so it's available for those of you that would like it. Orthognathic surgery is not to be undertaken lightly. It's complex. Steve Schendel feels like it should be a specialty among surgeons. There's surgeons in my community that tell me that they sleep better not doing orthognathic surgery, and there's not very many that are doing it in LA anymore. One guy who's the head of St. John's told me, he says, I could put a few implants in and make just as much money and I sleep better. You tell a guy who loves doing orthognathic surgery that, and he thinks, well, it's not only about that. And so here you see a young man who came in before and after for obstructive sleep apnea. There is his original malocclusion, or occlusion, let's say, a very tight occlusion, 4 bicuspid extraction, retrusive mandible, and then reduced nicely into a good class 1. But the landmine, look what happened. Who in the audience can tell me what happened? There he is before surgery. Everything looked good after surgery for about 4 weeks. And then 4 weeks later, boom. Boom, what happened? What was the cause of that? What is it? Condyle is out of the fossa. Condyle is out of the fossa. That's a problem. Condyle is out of the fossa. That's not going to help. And then you put on top of that a heavy clencher. What else can you see that's going on over there? Mike? I know that you can see that. What else is the problem? Condyle is out of the fossa. He's clenching 4 weeks into it. Boom. Double bracket, and he bends it and then breaks it. Boom. Got to take him back into surgery. And we've got to put some reconstruction plates on because he's a clencher and grinder. We've got to get that condyle back into the fossa, and then we've got to reduce him properly. So I want to finish with 3 cases that will sort of highlight the changes that have occurred in the last 33 years. These were maybe a little bit more simpler cases to illustrate the point. They're treated very differently. Case 1, 2, and 3. The first one was treated in 24 months. The second one was in 12 months. And the last one was that one you saw earlier was my architect friend's son, the guy with the open bite, that we treated him start to finish in 6 months, in and out. And the first one, all of them were open bites, degenerative joint disease, psoriatic arthritis, condylar resorption, and breathing difficulties with extraction, non-extraction. That was an average prescription. Second case, non-extraction with one of those more specific prescriptions, and the third one with non-extraction with a much more individualized prescription that we talked about. So here's the young girl. She was a friend of mine's wife. Reg Park was a Mr. Universe 3 different times. This was his son, John Park, big, strong guy, very holistic in his mind. And I looked at this case and I thought, oh my God, this is an orthognathic case. The mandible is retrusive, it's an open bite. She's got arthritis in the temporomandibular joint. She's got asymmetry, she's got breathing problems, she's got a crossbite. That's a problem. Orthognathic surgery. And he looked at me like I'm out of my mind. And then, my dead body, you're going to take my wife on the operating table. He said, just do something. And so Dr. Rickesheim joined him, and very soon after I joined him, he said, well, the only way I know how to fix that is take out 4 first molars. I said, take out 4 first molars? I've just taken your advanced course and you don't take very many teeth out. I don't think in the orthodontic school I ever did a case of taking out 4 first molars. He said, just do it. So we went ahead and took out the 4 bicuspids, and we brought all the posteriors forward, and we used all of the techniques that he taught me to reduce her fully. Just with orthodontics, and it took us 24 months, 2 years. By the way, moving that whole molar into a nice class 1. And there she is. I'll show you. There's her occlusion. We managed to nail it, bring it all the way down, get a nice result. She brings her kids to me now, and I have long-term records on her 25, 30 years later. I would take it on some of my lectures. Those of you that may be South America and all over. And I'll show them early. They would say, oh, it's never going to hold up. She's got arthritis in the jaw joint. And no, here she is, 30-year record. Nicely treated, 4 molar extraction. The second case was done in half the amount of time. He had psoriatic arthritis, a compound open bite. We used a much more specific prescription, but still not an individualized. But we took advantage of those the TADs, where we put a little temporary anchorage device in there. Years ago, when I'd been following the literature in Korea, and I said to him, Brad, I said, I've never done any of these. This was years ago. I watched the Koreans do it for years, and it seems like it's not a bad idea. And we've got these little TADs, and I think we need to do a 4th, but you want me to take a shot at it. And if you do, you're my first one that I've ever done, but I've been in practice a while, and I think I can probably give you a decent result. If not, we could always do the orthognathics. And he agreed to let me do that. And we got the psoriatic arthritis managed, and we had him on a little biotemplate for a while to take away some of the pain, got him quiet, made sure the joint wasn't active, and there you can see nothing left in the joint, really. There you can see the Rocky Mountain workup, and boom, we nailed him in 12 months using those TADs. Different mechanotherapy, different improvements, and I have long-term records in him before and after, showing 20 years later, happy man, good occlusion, nicely under control, and there he is. So contrast that to the third patient now. There's my friend's son, the architect, that compound open bite. On him, same story, he didn't want the orthognathic surgery, he's got the open bite, and we used the piezo, like what I was talking about, and some temporary anchorage devices. July, August, September, October, boom. Full reduction of an open bite using just a little piezo. Regional acceleratory effect, and some of the techniques that we didn't have years ago. from a compound open bite to here, to a fully reduced bite like that. I had Steve, just because I was a little insecure about some of those TADs, put some plates on today. I put those TADs in just as easily, but those plates are nice where we put the TADs on the inside, just pull it up. And you don't need very much intrusion in order to close the bite in the front. And you can see the changes that occur very rapidly, and the occlusal changes. And we did a little genioplasty to add a little bit. But here's a case of inline orthognathic, much like the others, and we're able to do it with a combination of things that we talked about.
How much did you charge him?
I beg pardon?
How much did you charge him for the second?
We haven't talked that much about it, but I do use the little T-scan for the equilibration. It's a simple device, but it's a little bit more electronic, a little bit more accurate. It can be activated right in the mouth really easily, and it will show you the timing of the occlusion in a little bit more accurate way than the articulator, where you can identify the high spots. You can put it into various excursions, and we tend to find it useful. So in the end, really, we're all after the same thing, happy patients with happy smiles, and I hope today that I've been able to show you some things that have helped me reduce the amount of time and enhance the results a little bit. Question?
What kind of orthodontic movement of the teeth do you get with the sleep apnea appliances? And how do you go about maybe preventing that?
Yeah, the question is, what movement do you get with the sleep apnea devices, and how do you prevent malocclusions? And it's a really great question and a problem. One of my friends is an excellent dentist up in Westlake, and he called me and he said, oh my God, he says, I'm creating these malocclusions. He's a dentist. And I said, that's not good. He says, well, I asked the patient, I said, you want to feel better, or do you mind if your bite is a little off? I said to Mark, I said, you have to do both. You have to do both. You can't just do one. He says, I send them to you afterwards. So that's his way of getting around it. So, as orthodontists, we have that advantage. We know how to control teeth. And on those cases that you know it's going to be an issue, you know how to control it. And so on some of these young kids, we're using the devices and moving the teeth under it. On a skeletal class 2, it's a non-issue. On a skeletal class 3, it could be an issue. But most of the time, with the knowledge that we have, it's easy to control. And long term, you won't see huge changes. And if they are, we can make, as orthodontists, we can control that.
Well, one of the rules of thumb is that if you, I've always thought anyway, is that if you needed about at least 8, maybe as much as 10 hours to get a tooth to start moving. So if you had a patient who was not in orthodontic treatment, and you made a sleep apnea appliance to anteriorize the handle, and it's a tooth-borne appliance, if you limited the time that you had the appliance in the mouth overnight, you might be able to limit the tooth movement. So is that an alternative?
Did everybody hear that?
Maybe to stay with maybe 6 hours a night to be on the safe side.
Did everybody hear it, or do I need to repeat that? Everybody heard it? Yeah, and you're 100% correct. With the limited amount of time, you get a limited amount of tooth movement. Having said that, there are some postural changes that can occur, and if it's incorrectly controlled, if you've got full coverage of the teeth, and you're holding them as a unit, like what you saw on the appliance over there, you're a lot safer on some of the appliances that are segmentals. You can get the movement of teeth. But I always agree with you and think the orthodontists are in an excellent position, number one, to screen them, and number two, with the knowledge that we have, we can control the bite, including what you talked about in terms of the time. And 8 hours is enough for most people to sleep, and usually not enough to get teeth if it's managed correctly, so it's not become an issue for us. The Foundation for Orthodontic Research has always been a futuristic organization, forward-thinking. Carl, you're ahead of your time. I always thought that. What you showed today is ahead of its time. And so I wanted to whet your appetite and show you 2 things that we're working on that quoted Robert Morrow, and he talked about good Kaizen, good changes. He also talked about Daniel and the shift age. There's 2 quick final things to whet your appetite that I hope to come back to one time and talk about. The first is robotics in orthodontics and orthognathic surgery. And we're working with a company in California to develop what we hope will be a little better control digitally, where you can look remotely and work on the patient. And the second is with stem cell regenerative medicine. In our office for the last few years now, we've had autologous adipose-derived stromal vascular stem cell station, where we will take fat right out of the patient under either local or general, and we will put it through our stem cell laboratory and go ahead and separate it out and then concentrate it into millions of stem cells. And then we have a little cellular counter, and early in the studies we would actually send it up to UCLA and we would grow the cultures to make sure that they were active. But we feel like that there is some enormous potential in regenerative medicine, not only for the heart and the spine, but also in orthodontics. So thank you very much for inviting me. And, if you would like to visit our office in Pacific Palisades, you'll find me a very hospitable host. Thank you very much.
Thank you, Richard. Thank you for this wonderful presentation. I'd like to take advantage now. We have the full group here to thank all of the speakers for coming here, for fully understanding our mission to revitalize, to make this bioprogressive community get back. You guys accepted promptly to come here for free, so they are really understanding that we need this new blood, we need this new power. So millions of thank you for everybody for coming out, especially for the professors. Thank you very, very much. So our next speaker.